so welcome everyone. Thank you so much for joining today's webinar, Identifying and Implementing Evidence-Based Strategies in Comprehensive Cancer Control Planning. My name is Ikra Haji, and I'm a manager with CADCA's Geographic Health Equity Alliance. CADCA's Geographic Health Equity Alliance, or GEA for short, is in partnership with the University of Iowa's Advancing Cancer and Rural Equity Lab, is excited to present today's webinar, which is the fourth and final webinar in our four-part Rural Inclusion in Comprehensive Cancer Control Planning series. GEA is a CDC-funded national network dedicated to reducing geographic health disparities related to tobacco and cancer. GEA provides free training and support to state tobacco and cancer control programs and their partners on how to reduce health disparities and improve the health of communities across the nation. We encourage you to visit our website, geohealthequity.org, to learn more and subscribe to our monthly newsletter. Next slide, please. So I'm sure we're all very familiar with Zoom by now, but I'd like to go over a few housekeeping notes. So all participants are muted by default. So for any general comments, please use the chat box. We will have a Q&A portion at the end of the presentation. So for any specific questions for presenters, please use the specific Q&A box. This week, you will receive a post-webinar email with the recording of the webinar, slides, and an evaluation survey. We kindly ask you to fill out the survey. Letters of attendance are given only upon completion of the evaluation survey. Next slide, please. I'd like to now introduce our presenter. Dr. Whitney Zahn is an assistant professor at the University of Iowa's Department of Health Management and Policy and is a full member of the Holden Comprehensive Cancer Center. Her research employs health services research, social epidemiological, and spatial methods to address rural cancer disparities across the cancer continuum and to evaluate access to healthcare services. She has a particular interest in reducing cancer disparities among rural minority populations. She leads the university's Advancing Cancer and Rural Equity Lab. Dr. Zahn also serves on the board of the Iowa Rural Health Association and co-chairs the Cancer Prevention and Control Research Network Rural Cancer Work Group. Dr. Zahn, I will pass it over to you.
Right, thank you very much, Ikra, and thank you all for being here today. This is, as noted, this is the fourth in the series of these webinars, and so really glad to have everybody here. Just to get us started, I'm going to have a very brief kind of orientation to the rest of our presentation, and then I'll turn it over to the real stars of this particular webinar. We have three great panelists who are doing really great work around rural cancer control. So our objectives for today are that I hope you can walk away with are to apply best practices for identifying evidence-based strategies to address rural relevant or rural specific objectives in comprehensive cancer control planning processes, and to identify examples of interventions and initiatives that have implemented these types of strategies that you'll hear from our panelists today. As Ikra noted, this is the fourth in a series of webinars. And you can see noted here the additional three that have been delivered over the past few months. And those are all linked on GEA's website if you'd like to review those. And these all build upon each other a little bit with regards to engaging rural in different capacities, whether it's from ensuring rural data are included in your plans or working with rural partners, developing rural focused goals, objectives, and strategies. And then today, taking that a step further and hearing from folks who have implemented these important strategies for rural cancer control. So just a little bit of why this particular webinar series. And this emerged from a report released from the National Advisory Committee on Rural Health and Human Services a couple of years ago, which really encouraged rural engagements in comprehensive cancer control planning processes. Now, they recommended for CDC requirement, but this is something that could happen even without that specific kind of mandate to address disparities in rural populations through comprehensive cancer control planning processes. So what kind of how has this been done in the past? This is something that actually myself and one of the panelists and some other colleagues and students took a look at, looking at plans, and many had some kind of rural elements included. and as well as, specifically having rural specific objectives. But there's certainly, opportunities for all of us to continue to engage rural and include rural in any kind of work that we do. So that's a little bit of the impetus for this webinar series and this specifically. And so the last webinar focused on goals, objectives, and strategies in developing those. And this is how we often see this, framed with each of those, including also tactics, which may be used as part of comprehensive cancer control planning development. This just gives some examples of how that might be done. And today we're going to focus more on the strategy side. But these strategies often reflect ways that we can tackle objectives. And the most recent grant opportunity for comprehensive cancer control programs at the state level specifically requested developing not just SMART objectives, but taking that acronym a step further and using this SMARTY objective approach. And that includes being inclusive and equitable. And I think that really ties to engaging rural communities and addressing rural cancer disparities as well. And important ways to do that are developing rural specific and rural relevant strategies. And so we point to frequently in cancer control, the community guide and evidence-based cancer control programs that are provided by the NCI. Examples shown here, and you'll hear more from the panelists on some of these things as well. But we recognize too that there can be limited funding for comprehensive cancer control planning processes. So there's really for implementation and evaluation. So there's really an opportunity to partner with academics, with others who are engaged in this work, to kind of advance the objectives, the aims, the goals, objectives, and strategies of your comprehensive cancer control plan. So we recognize fully that budgets are a challenge, but there's opportunity for partnership. So I just wanted to give us that little bit of orientation before I turn it over and have our panelists share some specific examples of how this has been done. So I note we have three great panelists here with us today. Dr. Jan Ebreth, who's currently at Drexel University and is professor and chair of the Health Management and Policy Department there. Dr. Jamie Stutes at University of Colorado is professor of medical oncology, and Andy Dwyer, who's with the Colorado Cancer Screening Program. I recognize too, all of these individuals wear a lot of other hats. And I don't want to get the font too small on the slide to include all of their other roles, but I encourage them to share that as relevant to their presentations, because they all do a lot of great work in rural cancer control. And so we're going to have each of them present a little bit on their work. Then we'll have a chance for questions from the audience, and I'll share some questions as well as part of that process. But I will go ahead and turn it over to Dr. Jan Ebreth to start us off. Thank you.
Great. Let me get my slides up and we'll get started. Okay, well, thank you for that introduction. I really appreciate it. Dr. Zahn, Whitney and I have been working together for many years, and I'm delighted to be able to present to you today about a project we undertook in South Carolina with rural health clinics to help improve their colorectal cancer screening rates. I previously to joining Drexel University was a faculty member at the University of South Carolina and director of the Rural and Minority Health Research Center at the University of South Carolina. So I'm new to Pennsylvania, and I hope to find ways to incorporate many of these lessons learned and project ideas in my new state as well. So just to give you a bit of background about colorectal cancer in South Carolina, you can see we have two figures that I'm presenting here on the incidence rates for colorectal cancer from the years 1996 to 2016, and then the mortality rates on the right going until 2018. And you can see that there is some overlap in these rates in the earlier years of our the graphics that you see, but that over time, the divergence between rural and urban communities becomes more pronounced. And although not shown here, a very similar pattern is found for colorectal cancer screening, where rural populations are under significantly lower colorectal cancer screening rates than their urban peers in South Carolina and nationally. So the U.S. Preventive Services Task Force made a recommendation change in 2021 to begin screening individuals as early as age 45. This was actually also recommended by the American Cancer Society earlier than this. So it used to just be that everybody aged 50 and up was screened up to the years of 75. But with this additional change, more people are eligible for screening, and that's an important thing to mention before we get started thinking about how we improve screening, because now we have this new group that is eligible for screening and doesn't always know that they're eligible for screening. Dr. Zahn also referenced the community guide. I briefly will touch on it here. This is a really great resource for individuals, practitioners, policymakers looking for what are evidence-based approaches. They are really kind of similar to the U.S. Preventive Service Task Force in their approach to being sort of an independent entity, but they're really useful to identifying what are science-based approaches that can be considered cost-effective and backed by research that clinicians and communities can put into play in their communities. They also, I have linked here to a guidance on the CDC's website on how to calculate the CRC screening rate in a practice. And this becomes more important as you begin to think about how rural health clinics in particular may struggle with this very basic sort of reporting step. Unlike FQHCs, rural health clinics are not required to report on screening rates or other types of clinical indicators because that's just not sort of how they're funded. Their approach is very different, and because of that, there is a dearth of evidence as well as expertise within rural health clinics on how to do this. So this is a good guide for folks to consider. So in the community guide, there are many different evidence-based interventions that were listed. Dr. Zahn presented a nice table of those. And in the context of colorectal cancer screening, there are interventions to increase demand for screening, interventions to increase access to screening, interventions to increase the provider's delivery of referrals and actually moving forward to screening at the patient level. And then we also have interventions to reduce barriers to care at the patient level. And some of those structural barriers or ways you can intervene upon those include reducing administrative barriers, helping with scheduling, trying to set up alternative screening sites or adding hours on the weekends or evenings, helping with transportation, and also providing appropriate language translation services for non-English speaking patients. So there's a lot of different intervention approaches that have been found to be effective. And in addition to these, when they are combined together, they're even more effective. So one of our approaches in our pilot that you'll hear about is we really encouraged clinics to consider not just implementing one of these interventions, but two or more, because we find that the actual evidence indicates there's a better result when you do. So we engaged in this pilot study. Starting in 2019 is when we began, and it was funded by multiple organizations, including the Federal Office of Rural Health Policy by an interagency agreement with the National Cancer Institute, as well as a South Carolina-based organization called the South Carolina Center for Primary Care. So these were the organizations that we used for to fund the study. South Carolina had previously been successful in obtaining a CDC grant to increase colorectal cancer screening in a select group of FQHCs throughout the state. These were not limited to just rural FQHCs, but there were some that were rural in the mix. And that project was really successful. So the goal of this project was to adapt that successful intervention approach to try to increase the use of these same EBIs that had been found to be to work in FQHCs, but in an RHC setting. And it's a 4-phase approach where we did a planning and adaptation phase at the beginning. Then we did a pilot test in phase 3. And lastly, we created a toolkit that could be used by rural health clinics and rural health clinic providers across the state who did not participate in our pilot, but could still gain some information from the lessons learned and gain some tools and access to resources they didn't previously have. So in our pilot, participating RHCs were required to choose one EBI from this list: provider reminders, client reminders, or provider assessment and feedback. When we actually went through the implementation process, however, all of the partner RHCs ended up choosing the exact same combination of EBIs. They chose provider and client reminders as their EBIs of choice, which actually made it really nice because we were able to, they were able to sort of have some dialogue between each other since they were doing the same thing. And our implementer, our program implementer was able to provide a similar type of training to each of the sites since they all had the same chosen EBI. In addition to that, all the clinics had some component of small media that they incorporated. Unfortunately, none of them were able to do anything to reduce structural barriers. None of them, changed their office hours, for example, or provided transportation or language translation services beyond what they were already providing. So that was, kind of disappointing, but also not as surprising that would be a difficult one to achieve, given the small financial benefit to participating in the study. Also, all of the clinics signed the 80% in every community pledge, which is something that the National Colorectal Cancer Roundtable has. They also give a lot of tools to providers, toolkits and things like that. So this was a step sort of to get the clinics on board with the goal and give them a set of resources to use. We began to recruit RHCs into the pilot in fall 2019, and although we had initially 6 clinics who expressed interest, only 3 clinics ended up being able to participate. This project fell right at the smack beginning of COVID, which was a real problem, not just for initial participation, but we had some clinics who had to, close their clinics for multiple weeks during the COVID pandemic because their staff was sick. So there were a lot of challenges to both participation and signing on to participate in the beginning, but also to being able to continue participating throughout the project, given those challenges. This is a recruitment flyer we used. You can see it here on the right. We gave this out at the South Carolina Office of Rural Health as an annual meeting, and we had a booth. We recruited clinics through that setting as well as through a listserv. I won't go through all of this detail because it's kind of a lot, but it just goes through what components were a part of each phase of this project, all the way from building partnerships, including working with an external advisory board of 7 people that were representatives of various state agencies, working with the clinics, not just to help them implement these EBIs, but we did things like provided professional education on what are the modalities of CRC screening that are effective, making sure they knew what the guidelines were, talking to them about what are all the EBIs that have been shown to be effective. We did all of that in advance of the go live date. We did a lot of help with technical assistance after the go live date, which you can see in the later phases. And towards the end, we tried to gather some lessons learned through interviews and surveys and created our toolkit in phase 5. So the key components of the EBIs that were chosen, for the client reminders, all of the RHCs created a postcard using the Make It Your Own website, where postcards have already been created. They're, interesting graphics, but in addition to that, the clinics were able to upload their own pictures, could be pictures of their patients or their providers, their doctor's office. They had all of their own branding that is added to the postcards, and they mailed those directly to patients who were due for screening, as well as some of them passed them out in the clinic or had them located in the waiting room. For provider reminders, some of the clinics focused on EHR alerts, others focused on things like placing a signal on the exam room door of screening eligible patients. That way it got the provider's attention before they walked into the room. And I'll show you the really cute little poop emoji that was created by one of the clinics to use in this regard. We also provided a really nice Go Live celebration box, which made the activity fun and got the clinic excited about the initiation of the project. In addition to all of those activities, one of the key components of this pilot was helping RHCs create standard operating procedures and process maps. And this is important because it helps the center think about how they can successfully do this EBI. They have to know their capacity to do it, identify, how they're going to do it. And this is an example process map on the right. We have process maps like this for various different screening modalities and processes. But the point is, it's really important for clinics not to just say they're committed to doing the EBI, but really take steps to work it into their clinical workflow in a way that makes sense for their context and how many personnel they have and what those personnel are doing. So the Spotlight Clinic I'll mention to you is Fairfield Medical Associates. They were an amazing team we worked with. You see the poop emoji on the top left there. This was created by one of the children of a nurse, and this was laminated and used to put on the doors of patients who were eligible for screening to remind the practitioner to bring it up. This clinic also created a friendly competition between their providers to see who could refer the most eligible patients for screening, and the winner received this nice bag of goodies you see on the far right. So they really were into it in a lot of different ways, and the practice after the completion of the project even invested financially by adding a new dashboard to their EHR that would give provider-specific feedback against their fellow providers in sort of a benchmarking way. So that really was a novel way to continue that competition between the providers and encourage participation. Here's some of the different staff perspectives that were shared in our lessons learned interviews. I won't read all these to you, but I will let you read some here. Really, the focus here is they identified a lot of different barriers, including things with the EHRs, the process of getting reports back from the gastroenterologist once or a lab once the fecal occult blood test had been read. There were all sorts of concerns with that, sort of closing the loop with that. And making sure that the providers were able to stay on top of the results of the patient's test. So in summary, sort of the barriers we identified were that RHCs do have a smaller number of staff. Their EHR systems often don't support the reporting needs to participate in a lot of research studies. We asked them to provide screening rates. That was a huge barrier. Many of them didn't have the capacity to do that, and one of our clinics had to eventually do it in a manual way because they couldn't figure out how to get a report run through their electronic medical records. So that was a real challenge. And also just from a larger funding perspective, unlike FQHCs, rural health clinics aren't given any funding to support personnel that would be able to do evaluation activities because that's just not the structure that they have. They have fewer people that can provide those level of services. So that was a challenge. We provided this toolkit, and if you're interested in it, I'm sure the slides that will be shared with you all, but the toolkit provides an overview of many of the things we've talked about today, including details about our Spotlight Clinic, the implementation of EBIs and what clinics should be considering as they ask themselves what they want to implement and how to do it. Other resources, it's very useful, and I recommend if you're interested in learning more that you check out this toolkit. It is intended for rural health clinics. That was the audience we had in mind when it was created, and this is all a web-based toolkit. There's no print version. And lastly, I'd just like to acknowledge my great team, all who were at USC at the time, but now who are spread out in different places, including University of Iowa, where Dr. Zond is located. Myself, I'm now at Drexel University, and I'd like to thank the funders who were a part of the ability to get this project completed. And I'll turn it over to our next presenter. Thank you. And I think we'll answer questions all at the end.
Okay, great. Thanks, Jan. And I think that was a perfect segue into the presentation I'm giving today. And I think I know many of you as I was looking at the roster today. So thanks so much for joining. I'm Andy Dwyer with University of Colorado. And I know Jamie is with us today too. And I think we have a couple of Colorado folks on. So I'm going to go ahead and jump in to also talk about colorectal cancer screening in rural Colorado. And one of the things I want to share, I think, is that when we really think about the rural nature of states, oftentimes we think of Colorado as Denver, metropolitan, mountains, but when you really look at 77% of our land mass, we really are in rural and frontier communities. And so we are a variety of flatland, mountains, and of course, a lot of different geographic type settings, which cause a lot of different interesting situations for cancer screening in the state as well. So just this is a note from or basically a map from our Colorado Rural Health Center, who's one of our great partners. And like Jan, a lot of our partnerships have been with FQHCs for cancer screening, but in terms of really looking at rural distinction, we are working with critical access hospitals and then also rural health clinics and a number of migrant health clinics as well. So what's interesting about Colorado, if you really look at our Medicare and Medicaid enrollees, we do have really in our rural and frontier area, a large proportion of the folks who receive this type of coverage in terms of health insurance are living in rural and frontier areas. And that's something that we really take into consideration as we think of access to care, as well as we think of the aging population throughout Colorado. Like Jan, we work with a number of our critical access rural health centers and the like. And if you really look at the number of clinics that are out and about in terms of the ones that we hope to partner with the statewide initiative we have for colorectal cancer screening, it's about 165 total rural health facilities that we're hoping to engage in our work at University of Colorado with statewide funding to really engage in cancer screening. And I think, of course, like many in other states and throughout the country, of course, rural in terms of looking at cancer burden, colon and rectal cancer is still quite high in terms of thinking about incidence as well as cancer mortality. But of course, we're really looking at that management of cancer screening with all cancer types within the work that we do, including lung, which I know Dr. Stutz is going to talk a bit about today. But really the opportunity for colorectal screening is prevention, early detection, and also with colonoscopy being able to prevent true late cancer diagnosis. We've worked extensively, I think, in terms of thinking about partnerships throughout the state. The Colorado Rural Health Center has been an active partner in terms of thinking about connections in our work. We've been thinking a lot about the data. And so even with our Office of Surveillance, as well as even population health within the Colorado Department of Public Health and Environment, we partnered a lot to look at what does it look like in terms of distribution of cancers throughout the state. What does it look like in terms of late stage disease screening rates? And so we have a number of tools at our disposal working with our state health department, as well as Colorado Health Institute, who also derives a good amount of data to look at what's going on with burden of disease. And what's interesting, as you can see, is that if you look at where the darkest areas are predominantly in rural and frontier Colorado, that darker area is where we see later stage disease. So cancer diagnosed in stage 3, stage 4, where it's harder to treat. If you look at some of the lower screening rates, so the dots, the little dots, some of the, the smaller dots that are more dark in that red color are the lower screening rates. And then if you see the more etched areas, that's where we see lower income and like a lesser likelihood of people having coverage in terms of looking at coverage for types of cancer screening where it wouldn't be out of pocket cost. So we use a lot of the surveillance data to really look at what we're doing in planning for initiatives. So for instance, in Northeastern Colorado, we do focus with our Cancer Coalition with a number of our initiatives and thinking about where we're going to focus, how we're going to have more discussion about cancer prevention and colorectal cancer awareness in this area. And then we really use these sort of tools to help educate our patient navigators and others who are involved in our work around how do we drive some really behavior change in communities, really thinking about either staying healthier because they have a lower cancer incidence or higher screening rate, or if they're in need and really wanting to drive that idea and message of preventive screening. How do we really tell that story of you're in an area that needs these resources? We'd like to bring more out your way, help your community stay healthier, and let's move these screening rates up and decrease the burden of disease. So I've mentioned a little bit about who we are. We are a statewide program who's been funded for about 15 years by our state tobacco tax dollars. There was a tax put into place about 15 years ago that drove the price of tobacco tax by about 65 cents per pack of cigarettes and smoked tobacco at that time. And essentially that drove a tax that ultimately ended up in a competitive grants program where we've been able to support and maintain a statewide approach to cancer prevention using evidence-based interventions through the University of Colorado to provide technical assistance to our safety net clinics all throughout Colorado, really with driving patient navigation, implementation of cancer-based EBIs, and colorectal cancer really being the focal point. But we've been able to grow the work around some efforts for lung cancer screening, as well as looking at hereditary cancer, but particularly really looking at systems change, patient navigation, how do we drive screening rates as the EBI in these safety net and rural health clinics. So we reimburse for patient navigation as an evidence-based intervention. We do some capacity building around FIT and stool-based testing, but at this time, most of the clinic sites really needed support for access to colonoscopy and for providing navigation into screening through colonoscopy. Like Jan, we do have some limited funds for barrier reduction. We do talk about technical assistance around barrier reduction, so transportation, language assistance, really thinking about how do people make sure and arrive adequately prepared for their exams, prepped, thinking about sedation and the like as it relates to colorectal cancer screening. There's a number of efforts that we put in underway from the Cancer Center to provide that technical assistance and support for those rural health clinics, but also really funding those navigators to be engaged in helping deploy evidence-based interventions and navigation ultimately to the clinic systems. So we're a system and we're a program that has been in existence for over 15 years. And one of the things that I want to say is sort of a cautionary tale a bit about what we've learned in rural communities. I think that when we started this initiative, we really were set to be statewide. We had access, we had resources. Through that time, our funding has dwindled a bit. Our money for direct access for paying for colonoscopy or treatment has subsided in terms of the grant funding. We can pay for that navigation, but ultimately the amount of overhead and the amount of time that it takes for some of our clinics to really participate for evaluation, for reporting, some of the things that are put into play, it makes it very difficult for our rural partners to participate. So unfortunately, we've seen a drift from about 50% of those participating in the clinic system now being about 30% of the population who are presenting or who are participating in the program. We ultimately know that there's people who are wearing extensive hats. We know reimbursement mechanisms and the amount reimbursement has gone down for some of the rural providers. But we also have to really, I think critically about how we partner with our rural folks in the future to think about if the types of EBIs and the programs and the way we're deploying them are really synergistic in a way that allows them to participate easily and to maintain good partnerships. Ultimately, some of the facilitators is that we have champions at multiple levels. They're really involved in the designing. I think we're getting a lot of great feedback about what is and isn't working in rural communities. And a number of them have been very, very much engaged thinking about sustainability planning for cancer prevention and control, not just as one EBI, as navigation. We're really thinking not even just about cancer screening, but how do they really think about the survival of a rural community and rural health center coupled with other types of chronic conditions, emergency rooms. And so I think they have a keen eye to sustainability. And we've learned a lot about even the reasons why people aren't participating and why they are participating in our programs. One of the other things, if I can get my slide to move forward here really quickly, I'm not sure. Can you guys still hear me okay? Are we doing okay? Okay, very good. So one of the counties that we've worked with, and this is actually a great partnership because through our Colorado Cancer Coalition, as well as looking at the partnerships with one of the CCSP clinic sites is Cheyenne County. It just happens to be my home county as well. We began partnering with some capacity building to increase cancer screening rates. And as I showed earlier, we really did use the data to show that Eastern Colorado overall has lower cancer screening rates, higher incidence of disease, and then access to services wasn't really where it needed to be. And as a cancer center, as well as in terms of the funding mechanism, there's a real drive to put efforts and resources out to rural community. We really got the community engaged in terms of thinking about where they wanted to move. So Keefe Memorial Hospital, the Critical Access Hospital, the Rural Health Clinic connected, as well as the community at large, have really embraced cancer screening as an area where they really wanted to devote more resources when they saw ultimately what the data meant in terms of influence and impact on the community. So in the work that we've been doing with them, we've been developing and implementing workflows for colorectal cancer, lung cancer screening, hereditary cancer screening. Colorectal cancer and the navigation was the name of the game. But now with Ambry Genetics, we've been able to implement some great tools in terms of screening for patients for hereditary cancer with Dr. Stutz and team. We've been working with cancer screening and lung cancer screening and really thinking about how do we make the most of the preventive cancer screening process overall. So these are some of the great things that we've been able to accomplish. Even right now, even within the first quarter, we've been able to do 109 genetic assessments. So that relates to colorectal cancer screening, but also really looking at the impact of hereditary and familial syndrome within the systems. And for a rural community that only has about 1,000 people within the entire county, getting people engaged to already really think about preventive cancer screening and also ultimately hereditary and genetic cancer has been a big win. And I think that's because we engaged the Rural Health Clinic, the Rural Health Center, our Cancer Coalition, as well as all of the healthcare facilities in the area to really embrace cancer screening overall. So I would just say, again, I think we've had some great wins in Colorado around implementation of evidence-based interventions, but I think there's a lot more we could be doing. And I thinking, a one-size-fits-all type of approach isn't something that particularly works in Colorado. And so I think that we need to really be considering in the future that, of course, working with the safety net at large is something that we need to consider, but FQs in rural communities versus urban communities, those are very different settings, and we need to think of this very differently. So I'll turn it over to Jamie moving ahead, and thanks so much for the time.
Hello, everyone. As I transition to pull everything up, I appreciate the opportunity to present to everyone today on something that I find very passion-inducing in terms of work and lung cancer screening, particularly in rural areas, and the importance of really bringing this opportunity to the communities that have so much potential. And I'll be taking, kind of building off of what Dr. Everth and Andy have already presented, and going a slightly different direction, because they highlighted, working with primary care, working at a community organizational level. My work that I'm going to share with you is actually working toward expanding access to lung cancer screening by infusing support for lung cancer screening programs, expanding their skill sets and expanding what they need to do to reach rural communities. And so I have a few conflicts of interest that I don't see as conflict of interest. I see as working on the issue with any partner who is willing to engage and reduce the burden of lung cancer. So I view lung cancer screening as currently the greatest missed opportunity to reduce cancer mortality throughout the U.S., not just lung cancer mortality, but overall cancer mortality. The data are clear on this, that the last few reports on the burden of cancer mortality in the U.S. have shown that the declines in cancer mortality are largely attributable to outcome changes in lung cancer. And as we and yet we've not barely scratched the surface on the potential of lung cancer screening in terms of implementation. And we've only reached a point where we're at 6.5% of broad uptake of lung cancer screening among eligible people in the country. And if we were to achieve better implementation, particularly in rural areas, we could see that continue to reduce the burden of lung cancer for families in the United States, and particularly rural families. But in many ways, we have the ideal setting for implementing lung cancer screening. We have incredible data from the National Lung Screening Trial that showed us up to a 20% relative reduction in lung cancer mortality. We have strong policy supports from the U.S. Preventive Services and many organizational guidelines that have been adopted to support lung cancer screening. Even some of the most apprehensive professional organizations, including the AAFP, have recently come on board with changes to show the value and encourage their membership to support lung cancer screening implementation. We have the Affordable Care Act that directly links with the Preventive Services Task Force recommendations, as well as strong guidance from the Centers for Medicare and Medicaid Services. But what we're now really up to is the challenge of really making sure that we have as many communities as possible that are served with lung cancer screening. And that has not been necessarily a very easy task. So I'm going to talk a little bit about the story of the Kentucky Leads Collaborative, emphasizing the work that we have done in Kentucky, particularly in rural Kentucky, addressing the topic of lung cancer screening. And when we started this work in 2014, Kentucky was #1 in adolescent smoking, #1 in adult smoking, #1 in lung cancer incidence, and #1 in lung cancer mortality. And you can see that that is not equally distributed across the country or even across Kentucky. You can see the magenta splotch over the beautiful Appalachian region of the country, showing that lung cancer was literally and continues to be an epicenter in Eastern and Appalachian Kentucky. But the Kentucky Leads Collaborative, with support from the Bristol-Myers Squibb Foundation, really engaged primary care clinicians in the effort to bring lung cancer screening to our communities. It also worked on survivorship care, which I won't talk about today, but we really focused on an area of prevention and early detection and helping rural communities and diverse communities receive access to high-quality lung cancer screening, and helping to engage lung cancer screening programs as an ideal platform to get out into their communities and not just sit around and wait for people to be referred, but to engage communities, both the primary care communities in their regions as well as the at-risk communities in their regions, to create a social norm of lung cancer screening so that it's not viewed as something special or a different kind of strategy. It's just another cancer screening that we all consider doing if we happen to be eligible for it. The provider education efforts were really outstanding and led by our colleagues at the University of Louisville Brown Cancer Center, where they put, through various platforms, whether it was the academic detailing, where we had sort of eyes on the prize and being able to meet and interact with individuals who were implementing lung cancer screening in their primary care settings, but large group presentations, online courses, webinars that were done. Nearly 3,000 primary care clinicians and their affiliated staff and programs were touched with a direct message about the changes occurring in comprehensive lung cancer prevention and control, with an emphasis on lung cancer screening. And that really helped us to achieve reach throughout Kentucky primary care practices, regardless of whether you're practicing in an urban or rural setting. Folks knew about the lung cancer screening opportunity and a potential to address the lung cancer burden in Kentucky. But shortly after that, implementation efforts really showed a complexity and challenges. We were screening the wrong folks. We weren't doing shared decision making. We weren't engaging folks in the process. We weren't really doing a very good job with getting it to the people that could benefit from this. And then we're hit by COVID, and that really complicated things. And so really thinking about how can we make this available to more individuals in a high quality manner. And so in addition to supporting the engagement with primary care, we felt strongly that we need to work with the lung cancer screening programs themselves to facilitate their implementation of high quality lung cancer screening processes and smoothly translate the results of the NLST and now the Nelson trial that I didn't highlight yet, but it's a European trial that had results that were very strikingly similar to the NLST and really robustly supporting the lung cancer screening platform for implementation. To do this work with the lung cancer screening programs, with a focus on the rural serving programs, we developed an index of quality. And we use this not just to focus on the radiology services or the operations of the clinical team, but really to expand the scope of the lung cancer screening platform as really a lung cancer control platform. It is really a unique opportunity to engage individuals with lots of different information that could potentially reduce their risk of being harmed by lung cancer, by a diagnosis, or by ultimate mortality. And so while we did include elements for screening eligibility, the operations and the radiology that are at the foundation of it, we included how are these being conducted in terms of multidisciplinary teams? How are risk reduction efforts being integrated into lung cancer screening programs? The cost effectiveness data is very clear that shows when you do a good job of integrating tobacco treatments, evidence-based tobacco treatments into the lung cancer screening setting, that it can have more value and more impact. Are we doing the participant engagement activities correctly? Are we doing shared decision-making? Not just because we're helping people make informed choices, but we're also building adherence and engagement and helping retain them, because we know that one-off lung cancer screening does not work effectively. We need continued follow-up. And so persuasive techniques that get people in the door but do not sustain their involvement over time may do as much harm to them as good. And so really, we want to help them understand the fundamental value proposition of lung cancer screening so that they continue to come back and participate actively in the lung cancer screening platform, because it truly is a process and not an event. And finally, the community outreach pieces, marketing and outreach with empathy and compassion and support, not using condescending or paternalistic or fatalistic or stigmatizing imagery or terminology or context in terms of how we reach out to this community. We know they have a history of tobacco use, but there's no reason to make that front and center as we help more people become interested or aware of the opportunity to pursue lung cancer screening. And part of that comes with persistent engagement with our primary care clinician colleagues, who are our referral sources to get this process going. With the QUIL system, which stands for Quality Implementation of Lung Cancer Screening, we would go into partner with a screening program site, do our QUILS assessment. And then when we did that, we would also pair that with a report back and a presentation to the comprehensive lung cancer screening program team and everybody that was engaged in the lung cancer screening process within a healthcare system, including their administrators and potential other support systems that were touching any part of the lung cancer screening process. As part of that feedback system, we made specific guidance and recommendations on how to improve the overall services and the engagement in the program. And we paired that with a resource portal, an online resource portal of information, as well as guidance, continuing education training for navigators to run the program, to do shared decision-making more effectively, resources to integrate consideration of radon exposure. And I didn't highlight it before, but talking about radon in the context of lung cancer screening is not because it's an eligibility driving force, but because it can, but because it is actually something that is an evidence-based risk factor for lung cancer. But we can use that platform to educate people about the importance of getting their home tested, getting and mitigated if indeed their home is exposed to radon at unacceptable levels. We also think this helps diffuse the stigma and bias, and that the lung cancer screening platform message needs to be, we're interested in improving your health. We're not just interested in you because you have a history of smoking. And then finally, we hope that all those resources in that system repeated over every period of 6 months would lead to improved quality and improved delivery of services to those community individuals. We were able to partner with 10 lung cancer screening programs across the state, from in Kentucky, we call it from Paducah to Pikeville, which touches tip to toe of Kentucky and reaches a lot of different folks. In terms of some of the outcomes from this project, we conducted some preliminary data analysis showing that in general, folks were pretty solid at baseline. They were, of the 10 programs evaluated, they were receiving about 68% of the quality points that were embedded within our system. But indeed, over time, with the feedback system in place and with the resource portal accessed, they were able to improve the quality of their program significantly over a period of 18 months. We saw that many of the aspects were consistently high in terms of quality delivery, focusing on the eligibility and the radiology and some of the patient or participant pieces of the equation, but there were some other areas that were consistently poorly being implemented in terms of tobacco treatment interventions and some of the other addressing secondhand smoke or radon were not being consistently implemented as part of these programs and really undercutting the potential value. Some of the other things that were inconsistent across our sites were the engagement of an interdisciplinary team or reviewing the radiology results, implementation of shared decision-making, and other less consistent aspects of really engaging our communities with responsible marketing and outreach efforts. But that's sort of an introspective look at how the program was affecting lung cancer screening program operations. But externally, you can see that the U.S. rate of some of the most recent data showing about 6.5% of uptake. But out here with the comprehensive community outreach, primary care outreach, and building extensive community relationships through the Quills process and the Kentucky Leads Collaborative, you can see that Kentucky is ranked second. And that Kentucky is not a state that is very used to being at very high levels of health indicators, particularly in cancer. We've done a great job on colorectal cancer screening to be somewhere previously in the lower 40s in ranking to about now in the middle 20s, so right in the middle of things. But Kentucky being number 2 is a real outlier, and that is evidenced by this slide that has a little bit older data showing that Kentucky is indeed one of the only states in Tobacco Nation, the states with higher tobacco use and burden, that's truly leveraging lung cancer screening on a trajectory that we can be a little bit more proud of. But perhaps this is one of the most exciting slides I've ever developed and ever presented, in the fact that it's actually, we can demonstrate that we're changing epidemiology of lung cancer in Kentucky. As you can see here from 2009, just using data from the Kentucky Cancer Registry, showing that about 80% of diagnoses of lung cancer occurred at a late stage from 2009 to 2014. But with the implementation of lung cancer screening occurring in 2015 and achieving higher rates as possible, as second highest rates, we've seen a 10% decline in late stage lung cancer diagnoses. You can look at that as, boy, that's not enough, and we agree with that, but this is amazing. I can extend this slide back to previous years, and that rate of 80% stays at that level, but you can see that this is trending and accelerating downward, and we've recently been informed that with the data release of the 2019 data, that this trend has continued to accelerate. And I think one of the things that will be readily apparent is that this wasn't, while the Kentucky Leads Collaborative and our work was at the center of this, it would be achieved nothing without the extensive community engagement of different organizations and entities, many within the state of Kentucky, but also others outside the state in terms of partnerships and collaborations, and really leveraging this opportunity for lung cancer screening in a predominantly rural state like Kentucky, and making sure that that is available, and that Partnering with our Kentucky Cancer Consortium and our state-based coalition was essential to help us secure the funding and the partnerships that established the Kentucky Leads Collaborative. And that while there has been substantial progress, folks, we're still at 18%. It's no time for necessarily a victory lap or claiming success. That is 82% of individuals that are still eligible for lung cancer screening that have not been screened in Kentucky. And if we want to bend that curve even more, not just in Kentucky, but in the United States more broadly, we have to work with our rural communities that suffer a disproportionate burden of lung cancer and risk for lung cancer based on tobacco histories. But we think that working with lung cancer screening programs to support their quality and helping encourage them to be part of the solution in their communities by doing outreach and engaging them and then building confidence in the optimal service delivery around lung cancer screening will help really change this picture and meet some of the needs of those communities.
Thank you very much to all of our great presenters on really important and successful work. This time we're going to transition into more of a Q&A session. So do want to open it up for questions, recognizing I know a couple of our panelists have to leave a little bit early. So please put any questions you may have in the Q&A box. I can start us off with the question what people are thinking. That being, and you all alluded to this in certain respect on how you were engaged with your state cancer coalitions. But because that's our audience here today, of course, and just would love to hear a little, if anyone would like to expand on that, how directly you engaged those or how those coalitions were involved from start to finish, or even in developing any kinds of initiatives or grant proposals or whatever that may be. And that would be great.
I would say for our project, our director of the Cancer Coalition in the state was a member of our external advisory board. So I do think that's a great way. But in our particular project, we found the State Office of Rural Health was the most engaged partner, because they, every state has a very different structure for their state offices of rural health. Some of them are very large, lots of personnel, lots of services they provide. Others are very small, 2 people within a state health department type of team. So depending on what your state has available, we found ours to be extremely helpful. They helped in the recruitment of the RHCs, in disseminating our findings through their listservs, and at their annual conference, they invited us to come. We actually brought our Spotlight Clinic office manager with us, and kind of had like a provider to provider discussion with all those who were in attendance who were FQHC providers who wanted to know, like, hey, how did this work? Did you have problems? And they could speak to each other on a peer-to-peer kind of network. So I think for us, they were involved, but less so than the State Office of Rural Health.
And Jan, I'll piggyback on that. I think we've engaged both. And I think I talked about the State Office of Rural Health as our Colorado Rural Health Center. And I think you're right. I mean, going to the PCAs or going to the groups who do the work with rural health, like that is the way to really get it done. But I would say for our statewide cancer coalition, the other thing I think we've tried to do is sort of help build that link between the two, where we're doing more work in thinking rural with both engaged. I know within our state cancer coalition, the executive director has been very supportive of the work when we're thinking about paired campaigns. So outreach, we did this coalition in communities coupled with our program to really look at rural engagement. That's been great. But from the get-go, we've used our colorectal cancer task force, which is under the auspice and under the umbrella of our statewide cancer coalition, as one of the kind of body part disease specific task groups. And from the beginning, they've actually been kind of quasi advisors. So I think, like Jan, you've noted, engaging them and advising in the program, but we have really used that group to help advise in the, the implementation, the deployment. Really, there's providers, there's people who are working in public health from all throughout the state. Our ACS reps, a number of folks that really sit in that place. And so I think we bring a lot of our kind of our plans, our products, our issues, where we're going. And we really work with the coalition. And I would say our statewide cancer coalition has been also a strong advocate of the work. I mentioned we have our statewide tobacco tax dollars through a competitive grant program. And we've really had to advocate to keep cancer screening and cancer really on the radar. And our cancer coalition has been huge with, I think, being that voice and that presence within the state, whether it's through this tobacco tax, whether it's through the governor's office, whether just to remind everybody that cancer is still a big deal. It's the second leading cause of death in Colorado. The leading cause of death amongst young people. And so I think they've been really good in carrying that mantra ahead in terms of advocating for our work and cancer screening and prevention in general.
Dr. Zahn, the Cancer Consortium in Kentucky was intimately involved from the beginning. They actually were the ones who originally approached with the opportunity from the Bristol Myers Squibb Foundation and brought us into the mix. They were represented on our external advisory board. We had just started a state-based lung cancer early detection network at that time as part of the disease-focused work that our statewide cancer coalition was doing. And I think we were one of the first states to have a state-based coalition around lung cancer specifically. And so they were just our very intimate partners from the very beginning of this and throughout this, and our champions, and they helped us engage other partners and bridge to them. And so we actually use the lung cancer network as our community advisory board for one of the projects. So there are just lots of different ways that we engage with partners through the coalition and the established relationships there.
Thank you. Thank you all for sharing that. There's a question for Dr. Stutes on the work being in Kentucky, but you're now in Colorado. Was this a mostly virtual, or is this, can you talk a little bit about how that worked?
Yeah, so I continue to have research that we do in Kentucky with many partners there, and so I do some of it virtually, but I also make now that the pandemic is under better management and making more frequent trips. Just got back from Kentucky there actually yesterday for a community advisory board event, but just unwilling to let go of the community connections and the opportunities there to continue to improve on the trajectory of lung cancer screening there. But obviously working with Andy and the coalition and Christy Cahill here in Colorado is an important piece of next steps, because in all honesty, Colorado is uniquely bad in terms of lung cancer screening. We have not been one of the states that's leveraged this opportunity, and yet Colorado is one of the states that's known for being a bit healthier on most health outcomes and around cancer screening and other things. Diet, physical activity, nutrition, healthy things. But Colorado is in the neighborhood of 40th in terms of implementation of lung cancer screening, and a lot of those issues are rural and engaging our rural communities and really helping to bring lung cancer screening into more places and have a broader swath. I don't know, Jan, were you part of the geospatial group and the state-based group that did the paper on the cancer paper published in Cancer, showing that the percentage of individuals that don't have access to lung cancer screening within 30 to 40 miles, it's an uninspiring but very important outcome. I don't think, we're at a very unique phase of implementation of lung cancer screening. We're, just recently born in reality, and we got a lot of things to figure out. But there's just a lot of opportunity there, and another thing that we can do if we do it right. But we have to avoid stigma, we have to avoid fatalism, we have to avoid all the, pardon my, crap that we have inflicted on the community of individuals who are now eligible for lung cancer screening. We have to rebuild that trust, reconstitute that to help them view this as a valuable service that that can improve their health outcomes. And I see in the chat, there's also the inflatable lung, and yes, some of our partners that have those inflatable lungs and the different kinds of engagement around. But I really want our eligible community to be connected with lung cancer screening programs. That's the most important relationships. If individuals who live in Kentucky have never heard of Kentucky Leads Collaborative or any of our work, that is just fine with me. What they need to know is having on speed dial the navigator for the lung cancer screening program in their community. And that's where we really want to develop those relationships with primary care that can refer to those, that as well as just the community relationships that need to address in our efforts to create a normative social foundation around lung cancer screening, that it's not being perceived as something extra or different. And I know Jan and Andy and Whitney also have thoughts about that.
Just as a small follow-up, because I noticed some people in the chat box when you were indicating where you were from, there were several attendees who are participants and or directors or some kind of relationship with different American Indian or Alaska Native focused community organizations, coalitions, etc. This and Jamie can correct me if I'm wrong here, but this is a really great opportunity to as well for advocacy, because there has been very little attention paid within IHS to lung cancer screening and payment for lung cancer screening, like making sure that's a covered service. And by no means am I suggesting that all people who identify as Indigenous people are going to IHS, but I do think there's a real challenge to making sure that those services are provided in those contexts. Not just those services, frankly, a lot of different types of services. The scope of those services is really limited, but I just think there's a great opportunity for those of you who are in that space to try to do some advocacy around that, and especially from just making sure that those services are provided and paid for.
I think that's a great point, that there are still some niches, domains. One of the things that I really liked what you did, Jan, in terms of your presentation, is looking at a whole host of the community guide recommendations about, breaking it down into what is community outreach to the target populations, what is to the primary care clinicians, what is other to other groups to engage and to retain folks in these programs. And like we're seeing there's some questions around, we have to attend to the health literacy of these materials. We have to attend to the other communications, or the imagery that we use is very important. We cannot send out lung cancer screening messages that have tobacco industry. Unfortunately, we have some advocacy partners who are still addicted to fear and stigmatizing communications. Those are not our friends. Those strategies are not our friends in terms of helping engage people with the lung cancer screening opportunity and platform. We have developed as part of Kentucky Leads, we developed some materials that folks could use, but we also developed, importantly, what we call our best practices guideline for health communications and marketing around lung cancer screening, to avoid stigma, to avoid over-promising and under-delivering, and to really communicate the opportunity. We encourage programs to avoid persuasion. This is a stigmatized, fatalistic, skeptical community with low resources. When you try to persuade them, they recoil, they move away. We want to develop partnerships and collaborations and trust with us. If we sound like we're over-promising and under-delivering, we actually damage the relationship. We have to do lung cancer screening communications and outreach differently than we have done tobacco, how we have done other things. We have to put the community of individuals who are eligible for lung cancer screening at the center of the process. And it is not the scanner that's at the center. It's not even the navigator that's at the center of the process. It has to come from a fundamental understanding of the community that we're trying to serve and what will be appealing and attractive and engaging to them, not what we think. And I have slides and slides and slides of examples of how to do this terribly, in terms of if you want people with socioeconomic challenges to engage in lung cancer screening, do not put a picture of a CT scanner on your outreach advertisements. People see that, they say expensive and not for me. That's exactly the opposite of what we want them to engage with. We want them to see this as a viable thing that is uniquely for them and with them. And so we just really have to, so part of what we did was encourage our lung cancer screening programs teams to work with their hospital-based marketing to educate them about how to do this differently. Don't market lung cancer screening like you think you need to market a tobacco treatment program. That's not going to work. That's going to cause, them to recoil and move away from your program as to build trust and engagement.
Yeah, there's a couple other, I think some have addressed the questions around health literacy, but also I'm going to speak to one, partnering with regards to any materials that are developed for community members and patients, and then some other comments as well on smoking cessation as part of lung cancer screening programs, kind of getting, how does that fit in with, trying to not focus on stigmatization and those kinds of things. So, and then, sorry, there's a lot of questions in here about, alternatives to client reminders that aren't postcards, about if there's HIPAA concerns or other things. So those are all really good questions, and whoever would we prefer to panelists prefer to type those answers in, feel free, or to share out loud, whichever is most do we prefer.
Well, I'm one of the people that's supposed to be on another meeting right now, but Jill Price, you have a lot of great questions, and if you'd like to contact me by email, I'd be happy to answer them. But yes, I do advocate for empathic, evidence-based integration of tobacco treatment interventions into the context of lung cancer screening. That is actually part of every single guideline out there, but it's not a necessity. People don't have to quit to be engaged in lung cancer screening. As a matter of fact, if it's just another lung cancer screening is another platform to help engage people in cessation. But if they say no, they don't want to quit, that's okay. The relationship is important. They need to trust us, and we need to engage them empathically about that opportunity. But I am sorry, I really have to go. But it's been wonderful to get to talk about this, and I'm invigorated by the enthusiasm around lung cancer screening, as I know Andy and Jan and Whitney all share that enthusiasm for what an amazing opportunity we have that we're missing out on and not making as much about this.
Thank you very much, Dr. Stutes.
Bye, Dr. Zahn. Apologize.
Are there other questions that folks would like to share? Bring up. Dr. Epworth, were you able to answer the HIPAA related question around postcards? Okay.
Yeah, I was able to answer it. Yeah, there are other approaches. Telephone and text messages are other ways. Also, a lot of times there's patient portals where you can communicate a reminder to the patient. That there are potential problems with every approach. So for example, text message reminders, people may kind of ignore or block the person, or, it assumes everybody can receive a text message when that's not the case in every scenario. Like personalized telephone discussions, like a nurse, medical assistant calling and saying, having this one-on-one conversation, that's a great approach. Because we know one-on-one education works. Look at the community guide. There's definitely like a high touch level to that kind of intervention, though, that requires a lot of time and personnel. So it's just a matter of whether the clinics can provide that, but it does work. So that you have those sort of choices between automated, personalized, through the patient portal or through writing. I have never heard that particular issue with the HIPAA arise before. That doesn't. It may, one way to potentially get around that is, would the health system agree to you sending postcards to everyone who's age eligible? So that way you're not like targeting people who haven't done their screening, but just everyone who is 50, 45 and up gets this postcard. Is that not HIPAA compliant? I don't know. I've definitely received those kinds of emails. Postcards from my healthcare provider, but perhaps there are more strict rules that certain health systems are applying. So that's news to me.
And there's a question about state offices of rural health. And I can allow Dr. Eberth to talk a little bit about this, but South Carolina is fairly unique to, it's one of, I think, 3 states that the State Office of Rural Health is a nonprofit organization. Most others are either, like as she noted before, within a state health department or some state agency, and there's some also that are affiliated with universities. So I think the State Offices of Rural Health, they had a lot of other funding beyond. Dan, can you speak to that on if you remember?
Yeah.
On, is it like from the state and also probably grants and federal grants and all that?
Yes,
sorry,
the main funding for State Office of Rural Health comes from the federal government. It doesn't come from the state. So they receive like a appropriation through the Federal Office of Rural Health Policy, I believe, or HRSA. One of those. HRSA is with the Federal Office of Rural Health Policy is within HRSA, but they receive a federal appropriation per year. It's in the hundreds of thousands of dollars range on the lower end. And as a function of that, getting that funding, the state offices are actually required to match those dollars. So for, if they receive $300,000, for example, from the federal government, they're required to find matching dollars through grants and contracts for that amount. I'm not sure if they don't meet that goal, what happens, but I know that that's in the language that they are supposed to meet that. Now, South Carolina goes way over and above matching theirs because they receive a lot of grants and contracts from the state. For example, the National Breast and Cervical Cancer Early Detection Program within South Carolina, that program is called the Best Chance Network. They partner with the State Office of Rural Health to do a lot of their services. So it's almost like a subcontract to, run the program, part of the program out of that office, which is really great. So they are, really, really wonderful to engage, but it just really depends on the state's capacity to do it. There are other agencies though, and Whitney, I'm blanking on the name. What's the rural health clinic organization that Shannon Chambers is on the board of?
National Association of Rural Health Clinics.
Yes, National Association of Rural Health Clinics is another, it's a national organization that has rural health clinic representatives that come. So like another opportunity would be to partner through them for recruitment or dissemination of research findings. They definitely do have, they have a conference, they have, listservs. So there are national groups like that can also be useful, I think.
And Jan, one of the things that I found with our state Office of Rural Health is, although they have certain amount of funding, and I don't know that any agency like this is like robustly to the nth degree, but one of the things that I found very effective is we meet quarterly to look at our alignment of goals. And when we look at what they have and what we have, sometimes a little bit of us and a little bit of them goes a long way. And then putting in proposals together around shared aims. So I would say that, I think a lot of times even they're funded. But for instance, we have an eye care collab that is really around chronic disease prevention and management in Colorado. They need a cancer prevention partner in that work. And so when we have, basically pulled our resources together with the staff, they already have the travel budgets, they already have the technical assistance support, they need subject matter expertise, and a little bit of our budgets and time coupled with theirs has really made our cancer prevention and control efforts even that much stronger. So I would just also say that we've also gone in on a number of grant applications together. So one of the things is I think of how do you be a good steward and partner to help them move ahead. And I think when they also see that level of commitment from a cancer center, from a comp cancer program or the like, you just really see things starting to happen a little more effectively. So that's one of the things that we've tried to do is really keep in connection with our State Office of Rural Health, as well as our FQHC Primary Care Association as well. But being a partner to do things together is really, in that planning, has been super effective.
Thank you all for sharing that. Are there any I know we just a few minutes left in our time. Are there any other questions from the audience? We really appreciate the engagement, and all these are all really good questions, and I think really important ones. Partnership is a key thing. And just as another example to kind of put a plug in a previous webinar, we had a panel from here in Iowa, the Iowa Cancer Consortium, and then an evaluator who had a contract with the Illinois Comprehensive Cancer Control Program. That was a couple webinars ago. I think had a really good discussion around engagement as well, if you want to revisit that as far as new ideas for different organizations to engage. To wrap us up, I just want to remind you, I hope I'm sharing my screen correctly here. You can view past webinars at the Geographic Health Equity Alliance website. And again, there will be an evaluation form that we'd really encourage you to complete at the end of this webinar. Really value your feedback. And if there aren't any other final questions, you can see the webinar recordings and the evaluation survey there in the chat. We really appreciate your engagement and your participation in this webinar, and thank you all for being here, and have a good rest of your day. So thank you very much.